Acute glomerulonephritis or acute post-streptococcal glomerulonephritis. The term acute post-streptococcal glomerulonephritis is often used simultaneously with acute glomerulonephritis because it follows upper respiratory or skin infection with group A beta hemolytic streptococci in more than 90% of the cases. It's represented by subclinical course and nephritic syndrome. Subclinical course includes microscopic hematuria, mild or moderate proteinuria, normal or increased blood pressure in asymptomatic child, and finally, reduction of serum complement. Nephritic syndrome is a clinical syndrome characterized by acute onset of hematuria, dark coca-colored urine, oliguria, hypertension, edema, mild or moderate proteinuria, less than 3.5 gram per day. Etiology: infections, post-streptococcal infection, upper respiratory tract or skin infections with group A beta hemolytic streptococci, streptococcal pharyngitis in cold weather, especially serotype 12, streptococcal pyoderma in warm month, especially serotype 49, non-streptococcal, rare, viral, influenza, adeno-Coxsackie, cytomegalovirus, Epstein-Barr virus, mumps, measles, infective endocarditis, strep viridans, staphylococci, pneumococci, mycoplasma pneumoniae, salmonella, and finally shunt nephritis. IgA nephropathy, immune, SOE, Henoch-Schönlein purpura, vasculitis, iatrogenic, gold, penicillamine, metabolic diabetes amyloidosis, malignancy, lymphoma, multiple myeloma, others, toxemia of pregnancy, and Alport syndrome, glomerulonephritis plus deafness and eye disorders. Pathogenesis. Depression of serum C3 level strongly suggests that it's mediated by immune complexes formed against the nephrogenic streptococcal antigens. It's characterized by proliferative changes and inflammation in the glomeruli. The inflammatory cells damage capillary walls, allowing red cells to leak out. It's harder to pump blood through the glomerulus when it's all stuffed and full of cells, so the glomerular filtration rate goes down, leading to oliguria. Hematuria, deposition of immune complex on the glomerular basement membrane, leads to injury of the glomerular capillary wall, presenting by hematuria. Oliguria due to decreased glomerular permeability, development of glomerular intercapillary thrombosis, narrowing of the afferent arterioles, and finally tubular obstruction by casts. Hypertension, usually mild to moderate, mainly volume dependent due to salt and water retention, leading to hypervolemia. Edema, mild to moderate due to salt and water retention, generalized vasculitis, and development of heart failure. Clinical picture and complications. Acute onset. The age is young, most commonly between 3 and 12 years. Rare, less than 2 and more than 20 years. Usually there's history of streptococcal infection. Latent interval of 1 to 2 weeks after streptococcal pharyngitis, sore throat. Latent interval of 3 to 4 weeks after streptococcal pyoderma skin infections. General fever, headache, malaise, anorexia. Local, loin pain. Hematuria, universal finding. It may be microscopic or macroscopic. Macroscopic hematuria occurs in 1/3 of patients, leading to dark brown or smoky urine. Oliguria, it occurs in about 50% of the cases. Edema in 90% of the cases, mild to moderate in severity, appears initially in areas of low tissue pressure as the eyelids, puffiness, which is marked early in the morning, associated with mild bilateral pre-tibial edema, and may progress to involve the legs and other parts of the body. Pitting edema. Hypertension in 60 to 80% of the cases. It's usually mild to moderate, but in spite of that, it's liable to complications as it's acute and there are younger patients. Complications. Circulatory congestion. It's the most common complication in hospitalized children. Due to oliguria, it can lead to heart failure and pulmonary edema, dyspnea, orthopnea, and cough. Complications of hypertension. Hypertensive encephalopathy. Sudden increase in blood pressure impairs cerebral autoregulation, leading to cerebral edema. Clinical picture. Increased intracranial tension, vomiting, headache, blurring of vision, impairment of consciousness, cortical manifestations, seizures, hemiparesis, aphasia. Heart failure and acute pulmonary edema. Acute renal failure due to rapidly progressive glomerulonephritis. Investigations. Urine examination. Oliguria with high specific gravity. Glomerular hematuria, RBCs, casts, and dysmorphid RBCs up to smoky cola-colored urine. Mild to moderate proteinuria. Blood examination. Serum complements, low C3 in acute phase and return to normal within 8 weeks. Decreased serum albumin, CBC, mild anemia, dilutional, electrolytes, mild hyperkalemia. Evidence of recent streptococcal infection, anti-streptolysin ASO test, and antihyaluronic acid test, the best initial test. Throat or skin culture, renal function test, creatinine and urea increased. Renal biopsy, the most accurate test, is rarely needed. Indications of biopsy: Atypical presentation or atypical resolution. Atypical presentation, normal C3 level, absence of recent streptococcal infection, severe anemia, presence of nephrotic syndrome or acute renal failure, marked growth retardation. Atypical resolution, such as persistence of low C3, persistence of microscopic hematuria, proteinuria for 1 year, and impaired kidney functions for 2 months. Pathological findings, diffuse proliferative glomerulonephritis, light microscopy, hypercellularity, mesangial proliferation, inflammatory cell infiltrate, and occasionally epithelial crescents may be present. Electrical microscope, subepithelial humps, the hallmark of this lesion, IF or immunofluorescence, IgG and C3 deposition. Treatment, general, rest in the early stage till hypertension, edema, and hematuria subside. Regular measurement of blood pressure and daily weighing. Diet, decrease water, sodium, potassium, proteins, but increase carbohydrates. Drugs, antibiotics, single dose of long-acting penicillin G, benzosine penicillin intramuscular, 1,000,000 and 200,000 units. Oral penicillin V, 500 mg per 12 hours for 10 days. Erythromycin, 40 mg per kilo per day for 10 days in cases of penicillin allergy. Edema, salt restriction and loop diuretics. Hypertension, calcium channel blockers, ACE inhibitors, and vasodilators. Hyperkalemia prevented by restriction of potassium intake. If present, conservative treatment started immediately. Immediate dialysis indicated in severe hyperkalemia, acute renal failure, acidosis, uncontrolled hypertension, and pulmonary edema. Prognosis, it depends on the underlying cause. Nephritic syndrome caused by acute post-obstructive glomerulonephritis in children is generally excellent. Complete recovery in more than 95% of the cases. Rapidly progressive glomerulonephritis in 10% of adults and 1% of children. Differential diagnosis, acute exacerbation of chronic glomerulonephritis may follow upper respiratory tract infection, usually associated with marked growth failure and severe anemia. Other causes of post-infectious glomerulonephritis, other causes of hematuria, especially post-infectious glomerulonephritis. Hematuria occurs 1 to 2 weeks after upper respiratory tract infection or impetigo. IgA nephropathy, hematuria occurs within hours or days after upper respiratory tract infection, normal C3 and elevated IgA. Henoch 9 purpura, hematuria associated with palpable purpura, arthralgia, and abdominal pain affecting children. Good-Pasture syndrome, typically involving both lungs and kidneys. It's manifested by hemoptysis and nephritic syndrome. Lupus nephritis, chronic course with lupus manifestations, as we have previously mentioned in Rheumatology Audiobook. Hemolytic uremic syndrome, hemolytic anemia, bloody diarrhea, thrombocytopenia, and acute renal failure. It's the most common cause of acute renal failure in young children less than 5 years, associated with Escherichia coli, Shigella, Salmonella, Campylobacter, food poisoning. For example, undercooked meat or unpasteurized milk. Treatment, don't give antibiotics. Organism may release more toxins as it dies and may worsen the disease. Supportive treatment and early dialysis may be needed. Autosomal dominant polycystic kidney disease, characterized by presence of progressive cystic dilatation of the renal tubules. It's the most common inherited renal disease. PKD1, mutation of chromosome 16, mean age of ESRD is 60 years, and PKD2, mutation of chromosome 4, less aggressive. Clinical representation, usually asymptomatic until patients are more than 30 years. Positive family history, sporadic cases, no family history are also seen. Flank pain, hematuria are the most common presenting symptoms due to cyst expansion, cyst rupture, and intracystic hemorrhage. Infections and stones, associations or extrarenal manifestations, pancreatic cysts in 10%, liver cysts in 60%, berryaneurysm, subarachnoid hemorrhage, hypertension, mitral valve prolapse, coarctation of aorta, polycythemia, and diverticulosis. Diagnosis, CT and MRI are useful. Diagnosis is usually made by ultrasound by the age of 30. 90% of those cases would have variable-sized cysts in both kidneys. Treatment, non-specific, prevention of complications, early management of UTI, blood pressure control by ACE inhibitors and ARBs, necessary to decrease renal damage, and finally dialysis or renal transplantation. Metabolic acidosis, etiology, increased hydrogen ions or decreased bicarbonate. Increased hydrogen ions, high anion gap due to DKA, diabetic ketoacidosis, chronic renal failure, lactic acidosis, aspirin and methanol toxicity. Decreased bicarbonate leads to normal anion gap, diarrhea, pancreatic fistula, acetazolamide, renal tubular acidosis, Addison's disease, and ureterosigmoidostomy. Clinical picture: rapid, deep respiration, myocarditis. Clinical picture of the cause: hyperkalemia. Investigations: decreased pH, decreased bicarbonate, primary disturbance, decreased carbon dioxide. Investigations for the cause: treatment of the cause: sodium bicarbonate in cases of severe acidosis. Administration of bicarbonate in setting of high acidosis is controversial. Anion gap means unmeasured anions. Albumin is the main unmeasured anion. Normal value is from 8 to 12 milliequivalent per liter. It's used to determine if a metabolic acidosis is due to increased hydrogen ions or loss of bicarbonate. So high anion gap, the cause is increased hydrogen ions, and the normal anion gap, the cause is decreased bicarbonate. Low anion gap occurs in myeloma, low albumin, lithium, magnesium, and calcium. Metabolic alkalosis etiology: hydrogen ion loss or retention of bicarbonate. Hydrogen ion loss occurs in GIT loss, vomiting, nasogastric suction, renal loss, hypermineralocorticoid state, cons, Cushing's, exogenous steroids, loop or thiazide diuretics, volume contraction alkalosis, decreased chloride intake, and licorice ingestion. Hypokalemia associated with intracellular shift of hydrogen ions, increase in hydrogen ion secretion in the distal tubules. Hypokalemia leads to alkalosis, and alkalosis leads to hypokalemia. In retention of bicarbonates, excessive administration of bicarbonate therapy or precursors, lactate in Ringer's lactate, acetate, and citrate. Milk alkali syndrome, chronic carbon dioxide retention in COPD, compensatory mechanism in which there is increased bicarbonate reabsorption in the kidney. Metabolic alkalosis is traditionally classified as chloride responsive alkalosis and chloride resistant alkalosis. Chloride responsive alkalosis, characterized by urinary chloride less than 15 milliequivalent per liter, indicating chloride depletion. Chloride depletion stimulates bicarbonate reabsorption in the kidneys, loss of HCl, diuretics, and volume depletion. Chloride-resistant alkalosis, characterized by urinary chloride more than 25 milliequivalent per liter, caused by mainly hyperaldosteronism or hypokalemia. These two conditions may coexist. Clinical picture: hypoventilation, respiratory compensation for metabolic alkalosis, symptoms of hypocalcemia, tetany. Hydrogen ion and calcium compete for binding sites on plasma proteins, so decreased hydrogen ions leads to increased protein binding of calcium, non-ionized calcium, so decreases free ionized calcium. Clinical picture of the cause and manifestations of hypokalemia. Investigations: increased pH, increased carbon dioxide as a compensatory mechanism, and increased bicarbonate primary disturbance. Investigations for the cause: treatment of the cause. Treating alkalosis is probably not as important as correcting the condition. Sodium chloride, because volume depletion is common in chloride responsive metabolic alkalosis. Infusion of isotonic saline 0.9 NaCl is the most common method of chloride replacement. HCl in severe cases, and potassium chloride is indicated only for patients with hypokalemia. Respiratory acidosis etiology, caused by decrease in respiratory rate and retention of carbon dioxide, the same causes of respiratory failure type 2, respiratory center depression by opiate sedatives, anesthesia, head injury, airway obstruction, COPD, ventilation pump failure, myasthenia gravis, and Guillain-Barré syndrome, obesity. Clinical picture of hypercapnia, 2 C's, CNS manifestations, carbon dioxide narcosis, somnolence, confusion, coma, cerebral vessels dilatation, increased intracranial tension, headache, blurring of vision, pupillary dilatation due to sympathetic stimulation, cardiovascular manifestations, hyperdynamic circulation, congested conjunctiva. Clinical picture of the cause. Investigations: decreased pH, increased carbon dioxide, this is the primary disturbance, increased bicarbonate, this is the compensatory mechanism. In acute respiratory acidosis, renal compensation hasn't yet occurred. In chronic respiratory acidosis, renal compensation, increased bicarbonate reabsorption has occurred. Treatment: adequate ventilation. And finally, treatment of the cause: naloxone in case of respiratory center depression. Respiratory alkalosis etiology, caused by increase in respiratory rate and loss of carbon dioxide, living at high altitudes, lung disease, pneumonia, pulmonary embolism, psychogenic, hyperthyroidism, sepsis, fever, mechanical ventilation, Salicylate toxicity, direct stimulation of respiratory center causing metabolic acidosis. Clinical picture of the cause, symptoms of hypocalcemia such as tetany, investigations, pH increase, CO2, primary disturbance decreased, and bicarbonate is decreased. This is a compensatory mechanism. Treatment of the cause, breathing into a mask, rebreathing of expired air with its high level of carbon dioxide. And this concludes our part for nephrology.